Beautiful. All right. Well, good afternoon to all. Welcome to a presentation that is co-sponsored by the Critical Care and Proactive CL Psychiatry Special Interest Groups. The title is Critical Care Psychiatry, Can the Proactive Approach Work in the ICU? And I'm not going to bury the lead. The answer is obviously. So I want to cover a couple of learning objectives. I'm going to set the scene. And then we'll go from there. So learning objectives for today. Number one, explain what the principles of proactive CL look like when incorporated in critical care settings. Number two, discuss how systematic screening and early psychiatric intervention for critically ill patients can improve equitable access to psychiatric care and improve outcomes. And then third, describe how applying the principles of proactive CL can aid in disseminating critical care psychiatry. And so one big point that I want to make here in my presentation is that proactive CL represents a number of principles that can be applied to demonstrate value in what we do. And so it has largely been explored in hospital medicine settings. But ideally, the principles themselves would have greater value in settings with higher healthcare costs. So that's the proactive side. Critical care offers an opportunity for proactive CL to expand and to demonstrate its value in new and perhaps even greater ways. Critical care psychiatry, on the other side, is fairly new in terms of its expression. It's growing. It has a lot of interest. But the question becomes, well, how can we do this and package it in a way that demonstrates the value of critical care psychiatry? And so I see this as a win-win, both for proactive CL and for critical care psychiatry. So we're going to have 4 speakers today. I'm going to start by talking about the principles and kind of putting them into practice. Next, Joe Dragonetti will talk about the quadruple aim and really how this approach can begin to tackle each of the 4 aims there. Next, Jose Maldonado will talk about cardiovascular ICU, kind of what he's currently doing and the way that they are implementing it at Stanford. And then finally, we'll talk kind of practically, Dr. Bowie will talk about where do we go from here? How do we take those next steps in implementation? All right. So again, my topic is putting principles into practice. So I have no disclosures to report. But I'm going to begin with this, and this is the idea of what proactive CL is and what it aspires to do. Proactive CL aspires to meet the needs of inpatient medical and surgical populations. That is to say, proactive CL aims to take care of populations. It's not just putting out fires, it's identifying needs of a broader sample, of a broader population, and really identifying those and prioritizing those kind of as a corollary, an inpatient corollary to collaborative care approaches. But aspires is blue and in bold because that is an acronym that we're kind of trying to operationalize the different elements of this model of care. So in A, we advocate for patients, we advocate for mental health care, we systematically screen for mental health needs, we are proactively engaging with patients. We work as interdisciplinary teams. We provide care in real time, and we integrate our care delivery in real time. And then finally, it kind of the capstone is evaluation. How do you know that you've done what you've intended to do? How do you know you've done what you are aiming to do? And so in this presentation, each of the following slides is going to cover each of those major tenets as applied to critical care psychiatry. So the first step here is seeing the unmet needs. There is a classic article entitled "Gorillas in Our Midst," and in that study, they showed videos of the basketball being passed around and a person dressed in a gorilla suit walking right on through, and roughly half the people didn't see the gorilla. You're like, how could you not see the gorilla? Like, it's a person dressed like a gorilla. But the reality is, if people are focused on different things, they're not going to see something that otherwise might be obvious. So I kind of took a riff off that and thinking about delirium. delirium is in our midst, but we're not seeing it, right? So being able to, I mean, and by the way, in defense of, intensivists, they're trying to save people's lives. But at the same time, there are many other needs that are pretty obvious and would be obvious if simply we were to look for them. So this has been described as inattentional blindness. And so what is the response? When starting or thinking about critical care psychiatry and taking a proactive approach, we're really talking about a needs assessment. What are the pain points in that setting? What issues would they like to solve? We're asking questions. We're not telling them this is how you do things. We're going to our colleagues and we're asking them to tell us what issues they're having in terms of their daily experience. And then what are the strategic goals of the particular unit that we might be reaching out to? And we're really mapping onto the care flows that they already have, again, highlighting the needs that are already there. Number 2, systematic screening. You don't have to look all that hard. Now, there are many different ways to do screening. If you were collecting seashells and you went out to the seashore, that's not very hard to find, right? They're there. You're just looking for objective evidence, items that signal need. And so the issue here might be disparities or inequities in care, or perhaps simply just the historical model of reactivity. We're waiting for crises to happen, and then we just go to put out fires. But when we begin to screen, we're intentional about it. And when we're intentional about screening, we can overcome a number of those referral biases in different settings, specifically in the ICU. So when we screen, we're looking for things like acuity, severity, and complexity. And the earlier we get involved, the earlier we can begin to engage. Next, proactive engagement. So this is all about foreseeability. So foreseeable downstream effects. So I've always been surprised that there are a lot of people who live in areas that natural disasters keep happening. Move somewhere else. So in any event, there is foreseeability, and in law, right, we talk about, people have kind of liability if the outcome was foreseeable. But we know many of the outcomes of things that happen in the ICU, they're foreseeable. And so this is really about thinking about things proactively. Again, the issue here is every hour counts. In hospital medicine, we can talk about days. In the ICU, every hour counts because the costs of care are really pretty tremendous. So what are we doing? So one example that Melissa Bowie likes to talk about, and I think it's a great example, is really about supporting kind of the breathing trials. Because if you're not successful on day one, just because of behavioral activation or poor effort or anxiety or any number of other reasons, you don't try again until the next day. That costs a lot of money, and it puts patients back. They're more deconditioned. It's just a bad situation. So again, the idea of getting involved proactively so that we prevent these downstream effects, which again are in many ways foreseeable. All right, the next is interdisciplinary teamwork. And so this here, I say, start with what you have. And this picture is intended to be kind of an illustration of the phrase, a bird in the hand is worth 2 in the bush. Now, I'm not saying that you should go out and get birds and just kill them and eat them, but that's the idea, right? It's a lot better to start with the bird in your hand, because that's a sure thing, versus going out and trying to look for and go for the best or get more. What I mean here is in the ICU, they already have a team approach to care. There are many people in the ICU who work together, they round as teams, and essentially, you have physical therapists, occupational therapists, speech therapists, you have the full team, you have the pharmacist, and it's really about thinking creatively about the people who are already there and building capacity and bidirectional educational efforts. So don't let good be the enemy here of the best. In terms of our response, again, you build on current teams, you can build new skills, and really overall, the goal is to create an educational atmosphere. All right. moving on, real-time care integration is the R. And again, we work as teams. In general CL, unfortunately, very often it's kind of like SEAL Team 6. You rappel in, you answer the question, you never see anybody else, and then you rappel out and you're gone. And there's never any communication before the consult, during the consult, or after the consult. And that's horrible. I mean, and then we have the gall to say they didn't implement my recommendation, so I'm not going to go back and see the patient. You didn't even see if your recommendations were feasible because you didn't have a conversation. Maybe you didn't answer the question that they really wanted, right? So these kinds of conversations are essential to ensuring appropriate, effective delivery of care. And so here, just this idea that we weave ourselves into the team and we become part of the team. The issue is clear. We know this. This is obvious. Care discontinuity is everywhere around us. And so our response is real-time co-location. So this facilitates conversations. We learn their workflows and we work within them. We adapt to them. There are a lot of times that we might make a recommendation and it's a very time-sensitive order, either to discontinue something or to start something or to take one lab test or to check urine or get a bladder scan, any number of things, right? So time sensitivity matters, and weaving ourselves into the team allows us to be more nimble in that way. And again, it helps for care planning going forward. And here the final slide here of content in terms of Aspire is evaluation. And so here I have a picture of this idea of learned helplessness, right? So after a while, the dog stops jumping because it's like, it's just going to keep happening, right? So learned helplessness. And I'm so afraid that people in hospital settings today just believe the lie that this is normal. This is how it has to be, and this is how it's always been, and so this is how it will always be. But I think our response needs to be, very simply, this isn't normal, or doesn't have to be normal, and we can challenge it. So again, the issue is learned helplessness in its many facets, and really ICUs, I think broadly, are in need of a culture change. And I think that's something that proactive critical care psychiatry can offer, and it can offer in spades. And our response would be, I think, when we implement these, is really QI science. I mean, ideally, even, RCTs, kind of take the home study as an example and really do a randomized intervention trial, but thinking about outcome measures, process measures, balancing measures, evaluating kind of unintended consequences of what we're doing. So again, this is kind of putting it all together. Final slide, just thinking about it. We first advocate because we want to see the unmet needs. They are otherwise obvious. We just have to open our eyes and look at them. We screen systematically, which can provide equitable care and overcome barriers to access and the many biases that play into that. We get involved proactively because every hour counts for our patients, for our colleagues, for health systems, and the like. We work as interdisciplinary teams because we can build on the ICU culture of already working in teams. We integrate in real time by way of collaborating and providing education and learning ourselves. We're not coming in with all the answers. There are things we need to learn as well. And finally, as we evaluate, I really think, and this is true in hospital medicine culture, but I believe very much it can be the same story in critical care. We can change the culture because the way that things are being done around the country and globally isn't normal. Thank you guys so much. Perfect time.
All right, excellent. Thank you, Dr. Oldham. So good afternoon, everybody. My name is Joe Dragonetti, and so I'll be talking about this next part. And I have no disclosures here. So objectives of the next few minutes is we're going to be talking about some of the theoretical advantages of integrating CL psychiatry with critical care. exploring value in terms of patient experience, health outcomes, staff impact, and business metrics, and then reviewing sort of where we're at with the current evidence base. And so first, I want to start by acknowledging some of the challenges with psychiatry and critical care integration. So intensivists have long worked without psychiatrists, right? And in a context of critical illness, this has been one of the major hurdles, that other conditions are de-emphasized. And so I think this point right here really is illustrative of how the culture is shifting and changing. And so I was very fortunate recently to attend a grand rounds by Dr. Wes Ely, who's an intensivist and a real leader in the field. And he was, really emphasizing that point that Dr. Oldham was mentioning, where this doesn't need to be normal. And so in terms of the iatrogenic harm from ICU care and sort of the prolonged immobility, all of these medications, interventions that we're doing, and then also the big thing that he's really talking about recently is the humanistic aspect of ICU care, right? So this is not just a case. This is a human that we're taking care of. And, hopefully they will live. But if they do live, they're going to have sequelae from their course of ICU care. And so we need to know that while we're delivering that care and intervene as early as possible. So that's a huge shift that is taking place. And it's awesome, obviously, to see that it's not just psychiatrists that are seeing this, right? The intensivists are also seeing this. So we are aligned in that sense. And then another challenge is that many of our performance measures in CL psychiatry are imperfect. And so some of the things we have to work on. And so just in a general sense, when we think about psychiatry critical care integration, what are the areas where psychiatry can help? So agitation is certainly going to be one of the most common reasons for consults that we get to the ICU. And then the A to F bundle, implementing that sort of summarizes a whole lot of what we can help with. And so the A to F bundle is depicted there on the right. So some of the big points that psychiatrists may be able to offer help with: non-opioid pain control, sedation without respiratory depression, and then obviously the high rates of delirium, as we said, very under-recognized, and the related morbidity. Other things, there are obviously pre-morbid psychiatric conditions, new onset psychiatric issues, the traumatic nature in general of needing ICU care, whether it be the initial injury or illness or something about the care itself, education for patients, family, and staff, and then, like we were saying, bringing this quality improvement science, clinical trials, collaborating with our intensivist colleagues. So a big part of the way we want to conceptualize value here is utilizing the quadruple aim. So hopefully you all have heard of this, but we're sort of thinking about the question in a general sense: what are the goals and priorities for introducing proactive practices? And how do they align with the other stakeholders' goals? So that could be leaders in psychiatry, leaders in critical care, institutional leaders. And so really, if we're going to be working on altering some type of outcome or process, we want it to improve at least one of these things in the quadruple aim. We can hit multiple of them, that's awesome. And so what the quadruple aim shows us really is the components of value-based care, right? So how do we get the most for our money? And that's a lot of what the proactive approach is about. So when we start to think in a general sense again about what is the value of proactive critical care psychiatry, this may be some of the variables that we start to think about. And so we look at patient experiences. We want to get earlier attention to psychiatric comorbidity, which can have impacts for patients both short and long term. Patient outcomes may be related to things like delirium, agitation, and obviously mortality, very important. And then we start to think about business metrics: length of ICU stay, length of total hospital stay, cost of care, which can be total, that can be broken down into component pieces as well. And then treatment team experience. Obviously, many staff members are affected when there is patient agitation, certainly violence, right? It can lead to some very bad, very concerning outcomes. And things like team education, team support. So ICU is inherently a high stress environment, and creates a real potential for staff burnout, attrition, turnover, right, which makes the organization as a whole inefficient and kind of compounds lots of the challenges that we already have, things like short staffing, all those things. And so this essentially is what I think of as the brainstorm before the sales pitch. So this is not the sales pitch quite yet, but we want to kind of start thinking in these directions. And then in order to make sure we're not just saying, hey, look what we could theoretically do, we want to really make it real. And so that's where some of our QI science starts to come in. So I chose to use the model for improvement here from IHI just to pose some of these basic questions that can help us sort of conceptualize, make real what we're trying to do. So first, what are we trying to accomplish? How will we know that that change is an improvement? And then what change can we make that will result in improvement? And so what this is highlighting here is we need measurable targets. And so once we start to define our goals, then we can, from there, develop our measurements. And once we know what we're trying to sort of create or affect, that informs our interventions. And so sort of a stepwise approach, breaking this down and trying to make it a little more tangible. So now I want to take that same table and sort of if we're focusing on measurable goals, then these are some of the things we think that are going to be important to patients, important to treatment teams, and are hopefully things that we can measure. And so I think actually one of the biggest gaps here is probably this first box of patient experience. It's going to be one of the tougher things to measure. There's not like easy dollars and cents here. But what is the patient's experience of traumatic events? And so that can be just sort of subjective interpretation of how things went, but also obviously can be things like symptoms of acute stress disorder, post-traumatic stress disorder, new onset psychiatric conditions, both, while they're in the ICU, after they've downgraded to a medical floor, or of course, weeks, months, years later. All those things can be very important for the patient experience. And then we sort of lump in the family experience into this section as well, because we know that families can obviously be very strongly affected having their loved ones in the ICU, and also can have their own negative outcomes. So we can look at those things. Looking at some of the more objective patient outcomes, things that we can hopefully measure a little bit easier: time to extubation, as needed medications for agitation, restraint use would be a big one that I certainly know I see for a lot of our consults, right? Delirium incidence, delirium duration, mortality, substance relapse, against medical advice discharge, all these things that we might be interested in looking at. From the business metrics perspective, this is often what folks at the institutional level will be thinking and asking about. So we want to take into consideration length of ICU stay, length of hospital stay, total cost of sitter. So kind of trying to take total cost and break it down a little bit. Consult volume, time to consult, ICU throughput, right? So if we can decrease length of ICU stay, can we help the hospital, treat more patients in that environment? And hospital readmissions are, of course, very important. So yesterday, talking about looking at balancing measures, right? So if we're trying to decrease length of stay, whether it be in ICU or hospital in general, we need to make sure that, there's not a rebalancing on the other end where people are just ultimately getting readmitted. So there ultimately ends up being lots of different factors and variables that we're looking at. And then for treatment team experience, things like leader input, so may just be sort of objective variables there, but also codes for agitation, assaults against staff, staff attrition and turnover, and staff experience in general. And so you can see here that some of these are going to be more direct measures of what's going on with the patient. Some things like staff attrition and turnover are going to be much more indirect measures. Obviously, lots of other factors can be impacting that as well, but all sort of potential foci for projects interventions. All right. And lastly, we're going to look at the evidence base. So it's pretty limited right now. And proactive implementation has predominantly been studied so far in medical, surgical, or combined settings. So not a lot that's very specific to the ICU setting. But we're going to kind of go through some of the highlights of the evidence base, starting with a systematic review by Dr. Oldham. And so not ICU specific, but they included 12 studies. Some of the major findings with that was that 8 of those studies included screening by staff with mental health expertise, which then appeared to yield reduced length of stay and a favorable return on investment. And then they identified within those studies some other practices that commonly yielded benefits. So integrated care delivery, whether that be an embedded psychiatrist or multidisciplinary team, and unit or service level analysis. So that actually highlights, I think, very importantly, how this may translate well to critical care. And so critical care is already accustomed to working on a large multidisciplinary team, right? So they have that set up okay already. And then because we're working on a smaller scale on a specific unit, it's much easier to do that unit or service level analysis. We're not trying to look at the hospital as a whole, but we're looking at a much smaller subset. Hopefully all y'all were there yesterday at the plenary and heard about the home study. And so that again was not ICU specific, that was general medical wards. But they gave us some great sort of preliminary findings and information about what they found. And so it's not all that cut and dry what they found, and we kind of look forward to seeing how that manifests in publications and things. But it did kind of start to give us some insights. So I think a big takeaway there was that these interventions are cost efficient, right? And so it's very feasible to implement these things from a cost standpoint. And as Dr. Oldham was saying, costs in the ICU are much higher. So if you think about if we can, change something by minutes or hours, that may have more dollar signs next to it as a result. And so we'll kind of continue to look at those things. And then there are a few studies that are specific to ICU. And so this is from Dr. Bowie right here. Did a randomization for conventional consultation versus proactive with an embedded psychiatrist. And so they found shorter length of stay within this respiratory failure subgroup, but then also no difference for some of these other outcomes, right? So sort of some hints at benefits and lots of room to continue studying as well. Another study that we have, this was a prospective single institution cohort of adult patients in a surgical ICU. Basically, they're comparing usual care versus a psychiatrist co-rounding with the ICU team. This was basically, they reported negative results, so no difference in delirium incidence or duration as their primary outcome, and then also no difference in ventilator days, hospital or ICU length of stay, and in-hospital mortality. And so some questions I think were raised about the primary outcome. So is delirium incidence really an appropriate measure of the impact of a psychiatrist, right? And so we're kind of saying, no, it's not the best thing to be looking at primarily. And then also, it was interesting to see that both of the groups in this study were already implementing the A to F bundle very well. And so they're already attending to a lot of these things that maybe psychiatrists can help with. And so, they're probably doing pretty well to begin with. And so it may even be something to aspire to. And lastly, this is from Dr. Sadie, who actually talked a little bit about this concept this morning. But this is looking at the more longitudinal perspective. And so he did some observations in an outpatient post-ICU clinic, screening for PTSD, MDD, and GAD. And so certainly the initial 1-month screenings were very impressive. They had high prevalence of post-traumatic stress, anxiety, and depression. Fortunately, they did find that by 3 months, many of those symptoms had decreased. So PTSD positive screenings going from 2/3 to 10%. And really, this kind of starts to give us some insight into the natural history of these things. And so it's good that things get better over time, but certainly still significant and plenty of targets to be focusing on far beyond patients' time in the ICU. All right, here are my references. And so the way we have structured this workshop today is we're going to have pauses right now and at the very end for some Q&A and some discussion. And so we have some sort of topics we can bring up and poll the audience about experiences, but also please, if there's any questions about anything that Dr. Oldham and myself have covered so far, please raise your hand. Dr. Oldham is going to move around with the microphone so that we can support the stream and recording.
Is this, it is on. What questions do you guys have? I think you should put up the questions though. I think we Psychiatrists don't belong in the ICU and it negatively affects access to care elsewhere. Why would you even put a psychiatrist in the ICU? You're crazy. All right, what questions do you guys have?
Has anybody heard this? I mean, curious if you've looked at making changes and met with resistance.
No, I've had people say that they didn't want us in there because we'd start reading their minds. And just in a funny way, just that you're going to evaluate us, but joking. They seem to want us there.
Good. Over here, I think. Yep.
I just wanted to make a quick comment. So in terms of trainee attitudes about whether or not they belong in the ICU, it's been amazing to see the impact that Dr. Bowie has made at VCU, because when I was a medical student back in 2019, countless times residents were telling primary teams, call us back when they're extubated. We'll talk to them then. And now we do have a place in the ICU. So it's been great to see.
And so that's psychiatry trainees. I'm curious if you observed anything in the medicine trainees. Do you have them working there as well?
So the medicine trainees that I worked with when I was an intern back in 2020, they have seen firsthand the benefit that Dr. Bowie has had. And I think that's something that they, if they have left the institution, have hoped to see elsewhere. And they've expressed that to me directly.
Awesome. Great work, Dr. Bowie.
I think there's also not just medicine. We actually work with like neurology residents and surgery residents and all that. And when I was an intern a year after Elizabeth, the neurology residents loved what we were doing with it and had so many questions. I think NSICU, especially just because of neurology and psychiatry is like bond as it is at baseline. They've kind of reached out and asked questions. So
yeah, great.
So I saw there are questions here, but I also saw a hand here. So I'm just closer, but I'll get over.
I think I do have a quick question on how to approach maybe the surgical attending colleagues we have. I noticed the approach to us in the MICU is very different from the STICU. The trainees and the APPs seem to love us there, but I find that the attendings just don't really care that much about the impact on the brain. And it's hard to convince them why the brain's important. I was wondering if you had an approach to that.
Yeah, I'll let my colleagues
Sorry.
comment on this a little bit. I can say relationships is definitely a huge part of it, but there's also lots of variability. I did my fellowship about 10 blocks up the road here, and we could tell who was on covering the surgical ICU by the volume of consults we got, right? So somebody new came on Tuesday, and all of a sudden we have five new consults. So
I don't do a lot of ICU work myself. I've done it in the past, but not so much currently. I would just say kind of two thoughts. One is every clinician in every setting has sticking points and pain points. And the thing is, I think a lot of times those clinicians aren't connecting the dots about how the difficulties that they're having in one area might actually be driven by things that are perhaps distal to it or kind of maybe not as obviously related. So that's one part. The other part would be for those who tend to be more data driven or more just get it done kind of thing. If you show them data on how you're impacting things and can actually, have these evaluation outcomes, I think that also really endears us to them. And most of the time, I think most surgeons would probably respond to that.
I was going to ask on the concept of proactive care, of how that ends up coming out for billing and coding, mainly in the idea of, if someone has a stroke, we want to get them a swallow eval is pretty standard, and that oftentimes can be covered by someone's insurance. And on the concept of hospital leadership, definitely not losing money they'll go for, but they also like to hear when they're getting paid for the services that they're doing as well. So I'd love to hear your insights.
We are the second most profitable service in the hospital. But you have to listen to my talk. Just fun.
I was just gonna make a quick comment. So, whereas we're not consulted that much in our medical ICU, and it's fairly closed, as you've sort of suggested, our surgical ICU is a level 1 trauma ICU, and so we're very involved after general hospital medicine. Our biggest volume comes from our trauma ICU. And if you think of the population, we're in a suburban setting. So a lot of car accidents, people using substances, a lot of alcohol, a lot of people who have various drugs on board. So it makes the delirium management challenging, right? When there's substances involved, it makes the pain management very involved, right? If there's a history of substance use and pain. And then, of course, the traumatic brain injuries, which someone mentioned. So I think that's another very fertile area for sort of integration of the surgical and trauma ICU.
Yeah, excellent points.
Hi, I'm Eva. I'm currently working primarily with kids, but several years ago when I was still in training, I did a survey of the ICU of nurses, physicians, PT, OT, and pharmacy to see how they felt about having psychiatry currently in ICU and what they think would be beneficial to have. And we got a lot of comments on that anonymous survey, which was fascinating. Some of the things that came up was that the ICU docs did not really want us in there. They felt too many cooks in the kitchen because I think they have a plan for delirium that seems to be different than our plan for delirium. Pharmacists also said, well, we can do this. We can do medication adjustments. And then there was this notion that we would interrupt rounds and would focus too many on the social things and not on the medical things. And that there was an overall worry that family and patients would feel stigmatized by having a psychiatrist on board. So I think that there's a ton of education that needs to happen with our colleagues. And I think one way in, not that I have been able to do this, is also through nursing staff, because there's so many nurses. And I think the nursing attitude really matters.
Yeah, that's excellent points. And thank you for sharing that, because I think that's, a lot of the type of barriers that we're trying to sort of solicit from you all, because we know that for a lot of people in a lot of institutions, this is probably an uphill battle, right? To not only get into the ICU more, but sort of have a home there and introduce this proactive approach. So excellent insights. Thank you.
Just a quick comment on the question of like billing and value, besides directly billing for active traditional services or increasing maybe what you're doing that's billable. You can always make the argument it's going to be dependent upon your institution and what you're doing, but the indirect value. So, reduce nursing burnout, helping with transitioning to step down. There's so many things that, you brought up the example of like a speech eval or a PT eval, and there's so much more value to a PT eval than just what insurance pays for it, if that helps you get somebody to acute rehab, for example. And so we're doing the same thing proactively.
I'll talk as I'm coming up front. Nurses run the hospital. Okay. If you haven't learned that yet, you are behind the times. And nurses in the ICU really run things. I mean, the nurses are almost like practitioners in the ICU. So if you endear yourself to nurses, that can go a long way.
Thank you. At the institution I'm currently working at, there's definitely been interest from the ICU teams of having somebody from psychiatry on board. But our teams are just not staffed enough. Is there any way, like cut and dry, if I cannot spend all this time in the ICU and see all the other patients in the hospital, is there any way of doing something like this if they're if the hospital is understaffed from a CL standpoint?
I'll add a couple of thoughts. I don't know that I have the exact answer. I mean, this is in part, right? It negatively affects care elsewhere. That's kind of the idea there. One is you could certainly be targeted. Number two, you could, let's say, do rounds with, I'm just thinking out loud, you could do rounds with the critical care team and not really have as long of an engagement in the ICU, kind of later in the day. And so you're kind of there each day, but perhaps part of rounds providing almost a collaborative care type approach, kind of chart screening as well, and kind of providing curbside recommendations and so forth to start might be important. Also, I would just say, it's in most settings, but every hospital is a little different in the way that they do reimbursement. It's very often the hospital setting itself that's funding the consultants. They're paying for the salaries for the people who are coming in to do the consult work. That's not true everywhere, but I know that's a common model. And so if they see the value in it, then it's certainly something that they may be willing to invest more in over time. And really building capacity in the team itself, right? So it's not just that, wow, look, psychiatrists have an answer, but it's the education, it's the culture shift, it's the change, it's kind of working through the dough of these ideas of providing personalized care that addresses kind of recovery and experience overall. I saw one more hand over here. I think we have about 1 minute left.
I was just curious too, because it seems like one of the goals maybe for proactive CL, especially in the ICU, would be prevention of delirium. And I know you touched on that a little bit, and it looked like there were mixed results. And maybe that one team in the study that was mentioned was already doing a pretty good job. But I'm sort of thinking about prevention of delirium, and it seems like most of the work that has shown benefit in prevention of delirium are sort of nurse-driven protocols and screening and all of the things that come before we end up seeing people often. And so I was just curious about that as well, and how that fits in with proactive CL versus implementing these protocols.
Well, I think your question almost sort of gets to the point of the answer at the same time, is that by integrating and sort of taking this more proactive approach, you become part of the team and you can help shift the team's practices, right? Get ahead of things, as opposed to what we're used to doing is just reacting, right? And so what you're saying is that if we're just reacting, we're already too late. And so that's really where, like, the integration, being part of the team, we can help shift those practices even before the physician's involved.
And on the point of the study that was up here that said kind of a negative finding in that study, one big question I have about that study is it's not entirely clear. I mean, the intervention was they rounded with the team. It wasn't clear in my mind in reading the study what they did. I mean, they could have literally just been standing there all the time for all I know. It's not clear if they changed prescribing patterns. It's unclear if they were doing more kind of early ambulation. It's unclear if they were doing any number of different things. So I think this goes back to something that Dr. Gordon mentioned yesterday morning in the plenary, which is that just putting a psychiatrist somewhere is not enough. Right. That's the idea of collaborative care. What you want to do is implement an evidence-based approach. And so when we think about the way that we're doing things, we should be evaluating not only that we are putting somebody there, but that we really are measuring these effector variables as we go. And when we look at these outcomes, if we haven't changed the effector variable, then why would we think that the outcome is going to change as well? So this is kind of a mechanistic approach to thinking about the evaluation of an implementation science kind of model.
Yeah, so thank you all very much for your comments and questions. We'll have another 15 minutes at the very end to sort of take this a little bit further. So thank you. And now we'll hear from Dr. Maldonado.
I'm sorry, I'm writing a note to self, never to follow Mark Woolman in the presentation. First of all, I don't have his energy level, even though I'm twice his age. And second of all, I don't do rappelling. Bulldozer is more like my style. There's no clicker here there's no remote. So I have to stand here. I hate standing. I like rappelling better. Okay. Anyway, so hello guys. You probably are tired of seeing me in this meeting. This is my sixth and last talk, so I promise you don't have to see me again. I have a few disclosures, none of which are directly associated with this presentation, but I needed to be thorough. So I was asked to give a talk about the proactive model, and I want to use our experience at Stanford and how we created the proactive critical care psychiatry model first. So I came to Stanford in 1993, 30 years ago. When I came to Stanford, there was no formal CL service. There were psychiatrists from the inpatient unit who will run into the units, answer a call, usually a patient who was on a hold, and then they would run right back as soon as possible, just to make sure that nobody has a follow-up question. About a year later, I became the associate chief. I guess it was a testing position. And then a year after that, I became the chief of the consult service. I was the only psychiatrist for 5 years until I hired a second psychiatrist and then a third. And then in 2007, because I had a really good relationship with our cardiothoracic team, I started a kind of boutique consultation service with the CT surgeons in the ICU, which was an awesome experience. We will do everything together. I was scrubbing with them. We'll go drinking together. I went on procurement runs to pick up heart and lung to other hospitals. If you drink too much, then you forget exactly which one you're doing. But it was a great preamble to our bench spreading protocol. Now, and then things were going so well that the year after that, was asked to write this psychiatric aspect of critical care medicine, my critical care medicine program. And as you see, many of the people you know from the academy are listed there. So, but it was a great way to kind of involve and infiltrate their area of thinking. Some of the authors here are actually not psychiatrists, but they are from that place. Then we did together our first, remember, I was working with the CT surgeons. So we did our first joint study, which was that study comparing midazolam versus propofol versus dexamethasone. And it was the first study to demonstrate that dexamethasone can reduce the incidence of delirium, length of stay in the ICU, and cost of care. And 2 years after that, took us a long time. And in fact, the reason we did it in 2011 is because the board only was approved in 2010. So, and then in 2017, so in 2017, we got the hospital to fund a fully integrated proactive program. Initially, they were funding just my salary, and then slowly we added more people. Now we have 4 part-time attendants in the critical care service, and we rotate. The goals are as listed here: to bring psychiatric care to the ICU. And it was their question to do that, to switch from a just reactive model to a more proactive model, instead of putting out fires, to prevent the fires, and then to hopefully improve patient outcomes. And I'll show you that data a bit later. And how was I able to convince them doing that? Well, in few things actually worked to our favor. One is I was the chair of the Senate at Stanford, which gave me a lot of clout. So I got to bring myself in to talk to the president of the university and then the president of the medical center, and I brought this chart with me. And then shortly after that, one of the friends of the president of the hospital ended up in the ICU, horribly delirious, assaulted 3 of my nurses, ended up on restraints. And what happened? They called me. So I rappelled myself into the hospital, into the ICU, and saved the day. And then slowly, people start deciding, you know what, maybe we should have a shrink around us all the time. The other thing that I decided to do is I used to only wear French cuff shirts and very nice ties. And for those of you who have seen my photo, I only used to wear suspenders. Now I only wear scrubs. That's it. I'm one of the guys. In fact, I was at another meeting with my team. So we have one of the psychiatrists from the inpatient unit covering me for 3 days. And I came back on that Friday. I walked into our conference room where we do multidisciplinary rounds. And as I was walking in, the chief of the ICU was making a joke about the psychiatrist that was covering for me. And it was actually a pretty funny joke. The thing is that, I walk in through the door, the guy has the back to the door. So the guy who's in front looking at him goes, and then the guy turns around and he's like, Jose is one of us. And he kept on with the joke. And it actually was a pretty funny joke. So 10 years later, we were asked again to do a second version. And by the way, we're going to do a third version next year. So I'm going to be asking for a few more authors here. But as you see, we have been able to slowly kind of penetrate the field. And then we got really lucky because COVID happened, which meant there was a lot of horribly sick people in the ICU. We had a lot of burnout physicians and nurses in the ICU. And suddenly we permanently moved to the ICU because we were helping sedating people, we were helping managing agitation, and more importantly, we had a booth to take care of our colleagues in medicine and surgery who are very distressed. So that kind of like became, we became a permanent fixture in the ICU now. When I said in the last slide that now we have a full integrated system, is like instead of covering one ICU, which is the cardiothoracic ICU, now we cover all 10 ICUs at Stanford. In 2022, so last year, we developed a new track for critical care psychiatry. So we have 4 fellows every year. Now we give a fellow the opportunity to come into the critical care track. And we don't know if we're going to have to do more of that because fellows were fighting over who was going to do that. And just to give you an idea, this is what our critical care fellow track looks like. So as you see, they spend the bulk of the time on the critical care and have to run with me every day. But the rest of the time, they also have the opportunity to do everything that you normally would do in a good CL fellowship. Now, what does our team look like? Well, we have a dedicated critical care attending. As I said, there's now 4 of us, so we all rotate one at a time. We have a dedicated CL fellow. We have 1 dedicated PGY2 psychiatry resident. We have either a PGY2 or a PGY3 neurology or medicine resident. Sometimes we have both. We have a PGY6 critical care fellow. And then we have anywhere between 1 to 3 medical students. So there's a lot of people doing that, participating with us. And it's a lot of fun. We actually do it in a way that at the very beginning of the year, between July 1st and ACLP, I'm the attending, and then the fellows run with us. He's one of the trainees. And then next week, as we go back, the fellow becomes the attending, and I become their mentor. So I run with them every day. They do their stuff. I only jump in 1 or 2 occasions. They say something that I believe will harm the patient, or they call a friend. So if my fellow turns around and says, so Jose, what do you think we should do? I know that's my cue, like I started. Otherwise, I let them do whatever they want to do. Usually we stop running at about 2 p.m. We run to the coffee truck that is by the fountain in front of Stanford. I pay for coffee. And then I do a talk every day for half an hour. And after the end of the half an hour, everybody leaves but the fellow. And then the fellow and I stay attending, talk about how the day went and plan for the next day. Somebody was asking about funding. This is where our funding comes from. So Stanford Hospital pays off the top 20% of the position at Stanford. We have about 25% that comes from, 25% that comes out of research funding. And I'll show you some of where that funding comes. And then the rest comes from our billings. And we have an enhanced billing scheme. So you see that each one of the 4 attendings on the Critical Care Psychiatry Service is producing about 160 to 325% their WRBUs, which means I probably should go to Hawaii for 3 months, and that will drop down to 100. I tried to do that, and they say, no, I couldn't do that. We're developing a PICS clinic, which will have 2 medical directors, joint directors. One is a psychiatrist, and the other one is going to be a critical care physician. And the hospital is going to pay for that. And the proactive model that we have started with using the SPTD, the Stanford Proxy Test for delirium. It has been so well implemented that what is happening now is whenever we do rounds, the nurses start going by a system, and the first system is CNS. And guess what is the first thing that they report? They report the results of the SPTD. If the SPTD is normal, they move on to cardiac and then pulmonary. If it's negative, then we talk about the system together. We have been switching around, how exactly we're going to measure sleep, and we haven't figured it out perfectly yet. So if you have a good measure, let me know. And then we do some of the more classic other ways of doing demoralization scale. We're moving from the GADS and the HPQ to the HATS, and then we're using the civilian form of the PTSD scale. What exactly do we do? Our team rounds every day at 8:30 in the morning. So that's what we do. We get the consults in 2 ways. The proactive way is somebody scores positive, or if something happens, the nurses can call us without having to wait for the attendings or the primary team to do it. We also do daily transplant, daily rounds on the transplant patients for the CT, the cardiothoracic service, so heart and lung. We do daily liaison with all the teams. So my fellow and I divide the stuff and we talk to the teams. And then unfortunately, I have to do 3 weekly multidisciplinary rounds. So the CIV, ICU, the trauma, and the neuro. And it's a lot of fun. There's always unknown, there's always lunch. So I always get well fed. We have tons of joint educational activities. So we have a lecture series that I repeat to the neuro ICU and the CT ICU, etc. And then we do a lot of supporting activities. Every time we have a negative outcome, we just drop in there and we are part of the team. Many of the opportunities have to do with how our main advertisement is what the teams, particularly the nurses, tell the administration of the hospital of how awesome what we do is. It's usually not coming from the surgeons. They usually are not very expressive. So we also are doing a lot of research together. And the great thing about doing research together is that it establishes that we know what we're doing. We're creating science. But the best part is we invite them to be co-authors, co-investigators with us. So as you can see here, since we started in 2007, relatively frequently, we have been producing science. I'm sorry, my glasses are not working. We're producing science, and as you see, we have publications on and off, and each one of them, some member of the ICU is a co-author, and they're very happy not only to participate with us, they want to, in fact, sometimes they come up with projects and they say, what if we investigate this? What about doing this other one? And of course, it brings us to other places. So I tend to go to meetings for the, Cardiothoracic Society Association and stuff like that. And then you get invited to really cool things like that. So like in 2020, we got an NIA funded study to do precision anesthesia with anesthesia. And when we finished that project, then we got a $10 million grant from NIH to do exactly the same thing at greater scale. So before Melissa kicks me out, because she's about to do it, I can see that she's about to do it. I just wanted to finish. I spent so much time doing this slide. I just wanted to let you know that really to get something you had never, had, you actually have to do something you never did before, right? So you need to take risk and you need to find ways to engage enough that they want to take the same risk that we're taking. And believe me, they're more scared of us than we are with them. Thank you very much. Thank you for not hitting me. Video.
So much. All right. Well, thank you all so much for being here. And I'm just so glad to be a part of this team, hear everybody's expertise. I always learn so much when I hear these speakers. I'm Melissa Bowie. I'm at Virginia Commonwealth University in Richmond, Virginia. And I'm really excited to give a bit of a primer today on where to begin, practical steps that you can take to start integrating into the ICU. I have no disclosures, and this is the DEI statement from our group's proposal. In a moment, we're going to get into 3 objectives for this talk. We're going to talk about appreciating the spectrum of integration. Integrating into the critical care setting can look many different ways, depends on your availability, your time, your system's openness to it, your department's openness to it. So really talking about a lot of different examples of what this can look like, ranging from liaison models to fully independent interdisciplinary models. We're going to talk about the steps that a CL psychiatrist can take to develop an enhanced presence in the ICU and to create a self-sustaining collaboration. And we want to understand the importance of identifying metrics by which the CL psychiatrist can demonstrate the value that they bring. Dr. Dragonetti talked a lot about ways that the IHI's quadruple aim can show value. And we want to talk today about how we can take some of that and bake it into the model of what you're doing so that downstream you can look back and say, look at this value that I brought. So getting started, I imagine the people in this room are here because this is of interest to you. But just to speak a little bit more to that, the benefits of proactive critical care psychiatry are enormous. This is a population that is very clinically challenging. And for some people, that may be off-putting. You may say, I don't know that I belong in an ICU with the sickest patients in the hospital. But the reality is that once you start working there, once you start dipping your toe in the water of this work, you appreciate that there are more similarities than differences. This is a patient population with complex psychopharmacology, complex systems dynamics, and that your expertise as a mental status examiner really pays dividends here, that you're going to have skills communicating with intubated patients, with critically ill patients, patients in pain, patients who are delirious, that perhaps your colleagues may not have. You have so much value to bring. Secondly, this is a very overlooked population. As has been said a few times, ICUs have historically functioned without psychiatrists in them. So they may not necessarily see the need for psychiatry to be added. But once you start doing that work, you can demonstrate that value very, very quickly. Similarly, this is an overlooked population because of some things that we have done. Psychiatry historically may have pushed back on consults that came from the ICU. We say, call me back when they're extubated. Call me back when they're medically stable and they're ready to come to psychiatry. So we've done ourselves a bit of a disservice with that attitude, and that's something that we have the opportunity to change now. There's enormous potential value to patients in the system. I really can't emphasize this point enough. Starting with patients and their experience, being critically ill is overwhelming, it's painful, it's unpredictable for patients, for their families. So you coming in as an expert in this area have so much support and guidance to bring to the patients and to their families. Similarly to the health system, because ICU care is so expensive I've seen a range of estimates, but the first day of ICU care can range from anywhere from $7,000 to I've heard upwards of $25,000 for their first day. It tends to taper down, but it can average out at around $3,000 a day, $5,000 a day, with a low threshold to bump back up, depending on how sick or not sick the patient is. So this is an incredibly expensive care environment. It's been estimated using 2010 CMS data that ICU care accounted for 0.72% of the GDP. Almost 1% of our country's GDP went to ICU care. Huge costs. And as has been said by my colleagues, this is an environment where differences in hours make a difference. So if you, knowing that delirium responds to preventive and early intervention strategies, if you can get in and make small changes that decrease the severity or the duration of the patient's delirium, and then you find a way to measure that, it will have long-term huge financial benefits. And that's not even counting the benefits to patients. We did an exercise in our pre-conference course just a few days ago where we went through a patient's case and we looked at 4 potential decision points. And based on what sedative and what antipsychotic you chose for a patient, hypothetically, that patient either had an ICU length of stay of 5 days or 36 days. They either got extubated or they were trached and remained on the ventilator. So these differences matter. And these are things that you can be in the driver's seat for. Similarly, because of the high stakes and the high cost and the degree of autonomy that you can develop creating some of these models, if you do this in an effective way, you can essentially write your own job description. That's an unusual thing, but this environment permits that. And we'll talk about how. And it's economically self-sustaining, as has been visited by my colleagues. So just want to talk a moment about some of the different ICU environments. There are hospitals with a general ICU. I trained in a hospital that had a satellite called the Faulkner Hospital, and they only had one ICU. It was called the FICU, the Faulkner ICU. And they didn't care for 80% burn patients. They sent them over to the mothership. But there are some hospitals where the general ICU is sort of all you get. But larger academic, tertiary, and quaternary care centers tend to have a variety of ICUs. The medical ICU tends to deal with patients with respiratory failure. Those are patients that need endotracheal tubes or tracheostomies. They have patients with multi-organ failure, where you're seeing patients with multiple different hits simultaneously that are inevitably going to affect the brain. You have cardiac or cardiothoracic ICUs that has been talked about by Dr. Maldonado. These patients require postoperative cardiac care. They may require ECMO, very, very sick patients, complex pharmacokinetics and pharmacodynamics. You have surgical trauma burn ICUs. These tend to deal with patients that are acutely there for rapid onset, major traumas. Burn ICU patients tend to be a special subset because they tend to have very long lengths of stay, and their mental status tends to improve over of that long length of stay, where you may be serving more of a psychodynamic role or a supportive therapy role. Neurologic and neurosurgical ICUs deal with a lot of brain injuries. The patient populations have a lot of delirium. They have a lot of behavioral problems, complex pharmacodynamics, because these patients may not be eligible for certain kinds of treatments. And then pediatric ICUs are sort of their own cohort, but delirium is increasingly being recognized as a problem in that patient population. Lots of opportunities for a psychiatrist to integrate into a pediatric ICU. So how do you get started? You say, yes, this is interesting to me. I like this content. I like this clinical environment. I like working with teams. I see myself here. How do I get started? Where do I begin? So you want to start by identifying your stakeholders. And this is going to start at home. You want to start within your department. Who in your department leadership can you connect with to make this case, to say, this is an area of interest to me. I'd like to develop it further. You really need that departmental leadership support, because this is going to be expensive for you at the gate. There's going to be a high sort of start cost to doing this, because it's going to take your time. It's going to eat up clinic time, things that you would normally be making RVUs. You're going to have a little bit of time investing into the value of this. So you need them to be backing you up for that. You're going to use your departmental leadership to make connections to your potential future champions. And you need a champion in your target ICU. So for me, it's been in the medical ICU, and it's usually been the medical director. And it's sitting down, having a conversation, myself, the medical director, and my departmental leadership, to make that case, to say, this is what I'd like to do. Here's the background of evidence of why this has importance. And this is what I'm interested in doing as a collaboration with you. You want that champion to be designing with you what that liaison might entail. As long as you're getting their buy-in, that's when you can take this next step and conduct a needs assessment. And this is probably best done by asking to join rounds, and ideally maybe for a week at a time, so that you can say, I'd like to join rounds. I'd like to see what it's like. I'd like to see how I fit in with the team. You learn so much by going on rounds. Wear comfortable shoes. Wear comfortable shoes that you will not bring home. Okay, leave them at the hospital. Yes. All right. So when you're doing your rounding with the team to conduct your needs assessment, this is where you want to get at the fertility of the soil. Are they open and receptive? Is it full of thorns? Are they sort of blocking you out? You would probably want to talk with the medical director, your champion in the ICU, to pick an attending who they think is going to be open. Because even having an established liaison, there are some attendings that are wonderful and open, and whatever I say, they say, that sounds great. And there are others who not as interested and maybe competing with having too many cooks in the kitchen. So finding that good week makes a big difference. As you're rounding with the team, you want to keep track of the number of patients with psychiatric targets of intervention. And this can reflect whatever your priorities are. So if you say, I really want to be there for delirium, I'm going to look at the CAM-ICU. If I would be there for psychopharmacology, how many medicines that patient coming in on? Who's coming in on multiple psychiatric medications? That's the beauty of proactive consultation, is you can sort of slice the salami a lot of different ways. You can decide how you want to screen that population, but you want to be keeping track of that. And then you're going to use that data to propose a time-limited pilot. So you want to use case examples from rounds to support your proposal. You might say, there were 10 patients every day. I was there for a week. Of that week, I estimate I would have an average of 3 new consults every day, plus 2 follow-ups every day. And these are all high-level consults. These are all level 5 new consults, level 3 follow-up consults. Then you want to think about launching your pilot. And this is where you want to start small and grow. So a starting small approach might be a liaison approach, where you're just the liaison to the ICU. If they have an issue, they can call you first. Or you say, program leadership, I really liked this rounding with the team. I really want to do this more. Let me do this for the next 3 months. You want to think about sort of a time-limited approach. You would want to eventually graduate to a proactive consultation model. You could go there directly, but it's a little bit of a leap. And then an interdisciplinary team longitudinal follow-up is really the gold standard. That's a little bit harder to jump into directly. You want to incorporate outcomes data into your model. And this is where we talked about taking those IHI quadruple aims and baking them in from the outset. So if you can offer your pilot to one of the medical ICU teams, one of the ICU teams, most ICUs have multiple teams rounding simultaneously. So if you can round with one team or offer proactive consults to one team and leave the others as usual care, you've built yourself a natural experimental design that you can come back later and say, patients that got the proactive consults had these outcomes. Patients that were on the usual care arms that would have been eligible for the consult if they'd been on the proactive team had these outcomes. And now you can compare and show how much different the outcomes are in patients who you touched compared with the ones that you didn't. Make sure you're securing your necessary QI, IRB approval ahead of time, enlist departmental support for informatics, to gather and analyze data, statistical support, and then plan to iteratively revisit the structure and implementation of the model after a predetermined period of time. So you could say, I'd like to round with the team for 3 months, and then we're going to see how it goes. I'm going to have my data analysis period, and then I'm going to come back and show you the value of what I did. There's plenty of potential for collaborating with colleagues, so you can engage within the department, engage your colleagues where possible, so it's not just a one-man or a one-woman show, although if you do it that way, it's okay. You can go for a little while, and then you can make a case to hire more people. Lots of opportunities for trainees. I have a medical student who I work with every day. I've just gotten approval for a second, so they thrive in this environment. It's a wonderful place for trainees to come and learn, and you get to teach them about proactive consultation, about critical care psychiatry. It's a win-win. Outside of the department, you can offer to give talks on critical care psychiatry to other departments. And then outside of the institution, you can get involved, like through the Critical Care Psychiatry SIG. You can publish, you can find your niche, you can figure out which aspects of critical care psychiatry or proactive consultation really speak to you. Is it cardiothoracic? Is it pulmonary? Is it pharmacokinetics? Is it building programs? So there's so much opportunity within this domain. And this is something that we're all very passionate about. So I know my time is up. We're going to go to questions now. And I would just invite any of you who are interested in finding out more, asking more, saying, hey, I think this might work at my program, but I'm not sure. Can we have 15 minutes, 30 minutes, set up a Zoom? Let's talk about it. Absolutely. Absolutely. And with that, I'll end and we can go right to questions.
All right, so who has questions? We have 15 minutes. at this point. Just kind of highlight a couple of things here. We're really thinking about where are you in the process of launching or developing a critical care psychiatry service. And then we can think about this in terms of the stages of change, pre-contemplation, all the way to maintenance and development, right? So we're thinking about this, in the phases of change. But if you want to share something along those lines and kind of what is that? Relapse? Anyway, yes.
Hey, this is I'm Kelsey. I'm from VCU. I'm actually a child and adolescent psychiatry fellow. This is mostly for Dr. Maldonado. So I was very inspired that it sounds like you were pretty much by yourself doing solo CNL, building that department from the ground up. Unfortunately, I think that is the layout that I'm going to be entering. So how did you yourself prevent burnout during that time?
I have to admit that that is the best way to do it, because almost anything you do is novel. They think it's great, and they're not comparing you to anybody else. So don't feel intimidated by that. I think that you need to really choose and pick your battles. And Melissa was talking about this, right? So, for example, every time that I start a research project, I find somebody in a different ICU. Remember, we have 10 different ICUs. They're not 10 different units. It's like we have cardiothoracic ICU, MICU, surgical ICU, neuro ICU. So I start with one and only do it there. And then people start talking among themselves. And then they start gossiping. And then I get calls that, how come you're doing that with the neuro ICU and not with us? And then I go, well, maybe if you're good enough to me, I will do that. And then they start begging you to do it instead of you trying to impose yourself to it. So I think it's a matter of being really strategic, and being psychiatrists were pretty good at manipulating people. They're good at people. But it's actually a lot of fun. I mean, it's one thing is we know more about your medications than they do. And they don't know that. But when you start working with them, you start explaining to them why this medication is better than this medication and how the medication is actually metabolized, they start listening to you. And then they start asking questions to you. And unfortunately, you have to start turning off your phone in the middle of the night, because it will call you in the middle of the night to ask you. So then you have to start getting boundaries.
I'll also add that I think you probably know psychopharm quite a bit better than most intensive care unit pharmacists. Very often they'll say things and I'm like, that's not quite right. And then we go and I share a study. And so, your knowledge of psychopharmacology broadly is almost certainly deeper and broader than even the pharmacist in the ICU. Other questions? Another way to prevent burnout, by the way, is to have the energy that Dr. Maldonado has, even though he says he doesn't have as much energy as I do.
Thank you. I'm Amanda. I'm a fellow at Vanderbilt. We have been trying to do something similar moving forwards. One of the barriers that we have noticed is just these screening questionnaires. Who does them at your institutions?
I can give a brief answer to that, which is that I'm sort of making use of what's there already. So for me, I'm using the CAM ICU, and I've set up my EPIC list so that it sort of, I just open it in the morning and I see the whole MRIC, we call it the MRICU, but it's the MICU list sorted by CAM ICU. I can just sort of identify my patient population for the day that way. I previously did a lot of manual screening. It took a lot of time. And as I've scaled up, I just haven't had the bandwidth to do that. So there's always these trade-offs. But that's something that nurses are doing already. So I'm not sure how you would do something that's not built into usual care, except brute force.
So in my case, the nurses are doing it all. And the way I convince them, I don't know what is the way to convince them, but we started with the SPTD, right, which we developed for nurses to do screening. Now they own the tool, which means that they want to do the tool, and then they start coming over and there's, they start to talk about, well, we're concerned that there's so much trauma for these patients, and the trauma of the medical illness. Is there anything I can do for that? because they cannot see everybody. So I teach them how to do the PCL to look for, and then, and then they start doing it. And they say to me, I think this guy is depressed. And I'm like, well, what's the PHQ? I don't know. So they go and do it. And then they call me. Does that make sense? So to me, is how to seduce them to be part of the process. And now they know to call me when they have evidence that what they suspected is actually real. So it's not anymore, I feel the patient is depressed. The patient has a PHQ of 27. And I come and see the patient. Does that make sense? But I don't know. I mean, I don't know how he does. He rappels into the ear. Oh, you said that. Oh, yeah. Obviously, I was not.
Hi, thanks so much. Questions more directed to Dr. Maldonado, but please, everybody else, feel to chime in. When you talked about funding sources, basically over half of the FT came from the VRVU sources. Were those directly from the clinical services done in the ICU, or were they supplemented by other settings?
All I do is ICU care.
Okay.
So and I was the 346%.
Okay.
Yeah, I'm an overachiever. I've always been one. No, but so the hospital give us funding, right? And then we have we currently have 15 research projects going on. So that funding of 25% comes from pieces of different ones. So the balance we're generating from our billings. And we have become very creative about billing. So we bill the time that we spend with the patient, and then we bill add-ons when we go to multidisciplinary rounds and when we interview families separate from the patient's room and all the stuff.
Gotcha.
So, and in fact, we're going to publish something in our critical care seat about exactly that, how to become creative and legally creative with the bills, which is the key here.
I have a similar question regarding like screening related, but also in general. You talked about nurses run the ICU, and so I'm a cardiac transplant psychiatrist. So I live on the CVCT ICU, and my trouble has been that I do my best to engage nurses, form relationships, and I provide a lot of education on how to detect delirium, like going beyond the CAM ICU, etc. My trouble is that we have insane fast turnover of nursing staff that I work with them, and next thing I know, I don't know who you are because where's Jane Smith, and so how do you work in a setting where there's just continuous turnovers? And I think that's very I think a lot of people can relate to that problem lately, and making sure that you don't burn out teaching someone new every few months. And is there a way to be work smart and not necessarily work hard?
I'll just briefly say, I think in thinking of the different models, when I did the embedded model at Brigham and I was with the team every day, they knew who I was very quickly. It might take a little bit of time, but they would get to know me pretty quickly. Because as you can imagine, ICU teams turn over every week, every 2 weeks, whole new house staff, new attending. And if they don't know who you are, you sort of have to prove yourself every time until you get that reputation. And that's where it sort of moves forward. There's a trade-off. So the proactive model is much less hands-on. It's much less engaged. So it's more of that proving yourself and sort of demonstrating the value that you bring. I think being there and being supportive for nurses, because they're going through so much, they talk as well. And I think you get a reputation among them. And the nice thing is they're not rotating off every other week. So I think it's wonderful what you're doing to educate them. And I think my guess is it's having more of an impact than it seems when they're turning over, because I think for you to be there and for you to be supporting them and caring about their clinical experience, they're going to really see you as an advocate, and they do run the hospital.
And as I walk over, do you have something to say? Go for it.
I thank you for the comment, because that's exactly what we're trying to hear about, is sort of the efforts that you feel like are difficult and sort of those barriers, those points of friction. This is not really ICU specific, but my first 8 years as a psychiatrist were with the Army. And so in the military, high turnover is sort of built in, right? And so it's a continuous challenge. So I think one of the points there is you want to start to work towards building the system, right? And so you are probably excellent, right? But you want to start to build that system so that, regardless of who's coming in, you can train them efficiently and effectively, but also so that when you eventually go somewhere else, somebody else can step into the role and do have that same effect that you're having now. And so sort of trying to figure out what is it that you're doing, how can I train somebody else to do this, creating materials, manuals, handouts, those sorts of things, in addition to what Dr. Bowie was saying. Yeah.
So 2 words of wisdom. One, choose your friends. So I'm best buddy with a nurse educator for every unit. There's only 10 ICUs. So the 10 educators and the nurse manager, they have all the power, and they're not the ones that are transitioning all the time. So they will tell the ones that are transitioning who to talk to. The other one is you cannot be everywhere at all times. So the way I handle that is I have developed also the protocols that they use in the ICU, and they get disseminated. I mean, if I have a second for a funny story, when we just before we switched, the ICU was the last one to switch to Epic. I remember I had been gone, I think it was at the European Academy of Psychosomatic Medicine, and came back 10 days later. There's one of those traveler nurses there. I walked in and I looked at one of my protocols, and for some reason they have somebody, probably an intern, butchered my protocol. So I take my pen out and I go like this on the page and scratch it out. And the nurse comes running into the room and she says, "You can't do that." And I say, "Why not?" She's like, "That's the Maldonado protocol. I've been told nobody can touch that or you." She actually said that to me. As she's finishing the part, the chief of the ICU walks in and says, "Hey, Jose, where the hell have you been?" And she looks at me and says, "Jose, like Jose Maldonado, Jose." So, I mean, so, but the thing is, like, that protocol endured. She didn't know who the hell I was, but she followed the protocol. So, and ICUs they love protocols. So I think that the most important thing, if you create a protocol and you feel responsible for it, is making sure that it's a living protocol. It's not something that was created 30 years ago and continues to be there, but it continues to change, takes input in what they care about and what they're doing. And that way it just it precedes you. It doesn't matter that she didn't know who I was.
So from a trainee perspective, I think Dr. Maldonado, your example was with PGY2s and PGY3s are in your rotation. From our standpoint, we also have 3s and 4s that can join. But from a didactic standpoint, at what point do you start teaching your residents? What exact lectures are you giving? Because there are different ways to evaluate the patients that are kind of going through this, different assessments you have to do that you don't necessarily get with other kind of CL lectures or the other standard inpatient consults. So at what point have the different experiences of, like, when do you start teaching your interns? What are you teaching your residents? Yeah.
So my team gives when the interns are in the last month of their internship year before they become PGY2, we jump in there and give them a crash course as to how to survive PGY2. So we start with that. Every year, beginning on July 1st, we have something we call the Immersion to CL Psychiatry Series, which we do for the first 3 months of the year. And again, it ends when we come to ACLP. The reason we do it that way is created for the fellows, then all the PGY2s and stuff get it, and we record it. So it is recorded. When you come on your next month, you can actually watch the entire series if you want to do that. I mean, every attendant does things slightly differently, but I'm not kidding. I do take my team every day for coffee, and every single day I give a half-an-hour lecture on either something I think is important or whatever they call. So if she says alcohol withdrawal, that's what we talk about today. And we do that for half an hour every single day. So the way we see it, teaching never ends. And I would never hire a psychiatrist to work with me if they cannot be good teachers. They can be the best clinicians, but if they cannot teach, they're not hired.
We have one final question. I think we're up against time.
Thank you. This is more of a comment. I'm Yesh Nelajan from Sloan Kettering Cancer Center. We haven't yet started doing proactive consultations in our critical care, But one of the things we've implemented that really strengthened our collaboration was including critical care clinicians in our behavioral emergency response team. So in our hospital, whenever there's a behavioral emergency response, a psychiatry APP goes in along with a critical care APP and a critical care RN. So in the last 5 years we've been doing this, they've really become our closest buddies, and now we can more easily transfer patients to ICU when their agitation is difficult to control on the floors. We're really greeted by, let's use a dexmedetomidine, let's keep them in the ICU. So that's become a great collaboration. And during COVID-19, we helped them write protocols to help with agitation. And talking about protocols, they absolutely loved it. So the more collaboration, the better it is. Thank you for this great symposium.
So I think we are out of time. Thank you guys so much for your attention, the questions, the engagement. Now let's do it. Critical care psychiatry, proactive approaches. Thank you guys. Have a nice one.
And remember that there are two related SIGs. There's the proactive care SIG, and then there's the critical care psychiatry SIG. And we're always available, so just email us or contact us on our. You want to say something? No? Did I jump in? Oh.